Hi, my name's Rob Wipond. I'm a freelance journalist. I'm the author of this book, Your Consent is Not Required: The Rise in Psychiatric Detentions, Forced Treatment, and Abusive Guardianships. And the talk I want to give today is a piece of the book that where I look at how the flexible meaning of psychosis supports rising rates of involuntary commitment that we're seeing around America and Canada as well. I cover both countries in the book. So that's what I'm going to cover today. I want to start by talking about what I call the dominant story out there in the public, in the news media, that's pervaded by legislators and so forth. This sort of dominant story around involuntary commitment. You've probably heard it before. And that is that since the 1950s, we closed large asylums. There's about 95% fewer psychiatric beds today than there were at the peak era of large asylums. This deinstitutionalization process resulted in many long-term patients becoming homeless or imprisoned. And these people are typically described as being schizophrenic or psychotic, very seriously mentally ill. They're quote unquote out of touch with reality. They lack insight. People who can't see that they're mentally ill and so on. Sort of a lot of what I almost call caricatured images of these people are trafficked out there in the news media and by legislators. And along with this story is this notion that since that time, we've developed very rights protective mental health laws that make it nearly impossible to commit even the most dangerous people. But if we can, that forced treatment is a compassionate, respectful process that works for these patients, and they're often grateful for it. So that's kind of a story you'll hear out there a lot, these assumptions sort of embedded into the narrative. And what I show in the book and what I'm going to talk about today is how every one of these statements is either very misleading or completely false. So I'll start first with just talking briefly about what is a forced psychiatric intervention, because they tend to not be that nice. As soon as you put up any kind of resistance to a forced psychiatric intervention, all sorts of things can happen. Usually starts with a police apprehension. You'll be moved into a locked or semi-locked institution. There'll be security guards. There's threats and pressure of different kinds. Often you're compelled to sign in voluntarily, or you're asked to under threat that if you don't sign in voluntarily, you will be forcibly detained and your detention will last longer. Belongings are taken. Forced stripping may occur. It varies from jurisdiction to jurisdiction what actually plays out. But these are very common things I'm describing. There's restraints and seclusion that may come into play. Often antipsychotic drugs are used. That's the most common class of drugs used in forced treatment. Strong tranquilizing medications, and these will be injected if they're refused. Electroconvulsive therapy is still done against people's will on occasion. And outside of inpatient institutions now, there's growing forced treatment actually occurring in communities, in different kinds of settings, in group homes or elsewhere where people may be under some sort of a very explicit or implicit coercive court order of some kind and be forcibly treated. So how do people actually feel about that? Well, they don't tend to be grateful. There's hardly been any studies of that. There's one done in the United States that interviewed people after a year of forced outpatient commitment, and about 72% of them said they were still not grateful, even after a year of being forcibly treated. And about 28% said that they had acknowledged some benefit from the process. More commonly, what we hear from patients who've experienced this is that they found it humiliating, traumatizing, terrifying, brutal, like being put in a chemical straitjacket. Many describe short and long-term physical and emotional damages, and comparisons to physical and sexual assault are common. I emphasize even people who've personally experienced sexual assault in their lives frequently say that their experience of a forced psychiatric intervention was as bad or worse than their experience of a sexual assault. So that's kind of a really important, I think, contribution to the public dialogue that needs to be out there more often said. This is not a rare kind of statement. It's very commonly said. And also, we do see studies reinforcing that many people say there's heightened suicidal feelings after psychiatric hospitalization of some kind. And those studies have often found 100-fold or more increases in the likelihood of people killing themselves after they experienced even a voluntary psychiatric hospitalization, let alone an involuntary one. Now, what's happened with commitment criteria over the past few decades? Essentially, it's broadened everywhere, the criteria for mental health detentions. We do still have on the books the risk of danger to self or others, or harm to self or others, which is the one most people have heard about, and it's still there and it's common. But it's important to understand that any legal scholars that have looked at this, or any independent parties who actually attend hearings like myself, you quickly see that this is a very broad and flexible term, this notion of dangerousness. It does not apply to sort of criminal activities or real violence in that way. It can apply to those, but more often in a civil commitment proceeding, it will be applied much more broadly, for example, to situations where a person is just having difficulty getting to work, or a child's grades are falling and they're struggling at school because of anxiety. This is what's considered danger in this kind of a commitment hearing. As Michael Perlin said in his book, The Hidden Prejudice, he's one of the leading scholars on involuntary commitment law in America. The definition of the word dangerousness is vague, amorphous, and he said it inspires an "I know it when I see it" attitude among judges a lot. And that's what I saw as well in my research. Now, criteria have expanded far beyond this. So we now have a grave disability standard, it's called, around the country, which means that when people are having an inability to meet their own needs in some way, they can be involuntarily committed and forcibly treated. And we've now expanded beyond that as well to a deterioration criteria that many states have introduced. And in this, the law is essentially that if it looks like you could be committable in future, then we can commit you now. If you're at risk of deteriorating in such a way, either mentally or physically, then you can be committed. This is very broad criteria that are almost Orwellian in their nature, in how they're written, and just give psychiatrists enormously broad scope. So what's happened? Basically, involuntary commitment, psychiatric detentions have increased dramatically in the best data we have. And there's a caveat here in that it is very, very difficult to find this data, and a lot of states don't release any publicly. It's unclear if they even track it. In some states where we can find data, though, this is what we found. So a UCLA study looked at this, and they managed to find data in about half of the states in America and extracted this kind of information. We see many states, the sheer numbers have doubled in 5 to 10 years. In 22 states, just in a 5-year period, the per capita detentions increased 3 times faster than population growth. And that was about an estimated 1 million people per year nationally. And that averaged out to about 357 detentions per 100,000 people. And that's very high. That's more than double, triple, or higher than the rates in many comparable European countries. And where we have better data, where the data is more thorough, the numbers are even higher. So, for example, in Massachusetts, the numbers reached 875 detentions per 100,000 people. And an audit in San Francisco County specifically found that the rates were 9 times higher than the county had been officially reporting. The researchers literally called every single institution in the county and reviewed what had happened, and ultimately came up with a number of 1,600 detentions per 100,000 people. So that was 5 times America's already staggeringly high national average. So this is what's actually been happening around the country, and this is very underreported. You've probably not heard of this before. And this is happening in part because there are many more places to put people. So that narrative about us having fewer psychiatric beds is also incorrect. That focuses only on state hospitals, only on the large asylums. So indeed, yes, there's far fewer of those. But the intention was to build smaller facilities. And indeed, mental health funding has increased dramatically per capita since the 1950s, and many new types of institutions have been built. So in particular, we have psychiatric beds now, not only in these state and county hospitals that still exist, but in private hospitals, in general hospital psychiatric wards, residential treatment centers. Nursing homes have specialized beds now for people labeled with mental illnesses. The Veterans Administration and Department of Defense have their own hospitals with special psychiatric wards, and so on. And then there are also 24/7 psychiatric beds in assisted living, supportive housing, and group homes, and so on. These are often just not counted. We don't even have really good numbers in a lot of cases on these, but this is where a lot of the funding went, with the explicit intention of getting people out of asylums and into smaller community-based places where they could live long term. And it's important to understand that the numbers in the asylum era are often misrepresented too, and that asylums included many other different kinds of people in those era. So not only psychiatric patients. So when you're trying to add all of these numbers up, you need to quantify all of that. And I did quantify all of that in my book. And what I arrived at is wherever I could find fairly detailed data for all of these is that some states have double or triple the per capita numbers of beds from the 1950s.
When you are.
Now I want to get on to the key topic for today, which is how psychosis plays into all of this, all of these rising rates that we're seeing. What's really going on there? Now, psychosis is absolutely central to involuntary commitment. In medical and legal contexts, the concept of psychotic is often used interchangeably and in a sort of circular logic with phrases like lack of insight and dangerous to self. So a person might be alleged to have delusional beliefs of some kind, and then that's considered to be psychotic. And that will then be considered to be out of touch with reality. And then this leads into whether the person is disagreeing with the diagnosis or the treatment. And if they are, that's considered a lack of insight into the need for treatment, into a lack of insight into the illness. And this is considered dangerous to self. So all of this is kind of used interchangeably in a framing around a person to involuntarily commit them. And just to give you a sense of this, that I'm not just kind of making it up, because it can sound like that when it's just a layperson like myself and not a specialist saying this. How does the National Institute of Mental Health explain understanding psychosis on their webpage? Well, their definition of it is essentially some loss of contact with reality, quote unquote. That's all they say. The symptoms of psychosis, as far as they're concerned, are delusions, false beliefs, and or hallucinations. Those are the primary things. Of course, there are many other factors that can come into play, but these are the defining elements of psychosis: delusions or false beliefs and hallucinations. And this is mirrored even further, simply with a little more detail, in the Diagnostic and Statistical Manual of Mental Disorders. So in the 5th edition, they define psychosis essentially as delusions and or hallucinations, some combination of those. But more importantly, and particularly relevant to all of this, what I've been talking about is that while we associate psychosis typically with schizophrenia and the schizoaffective disorders, actually in the DSM and in medical and legal contexts, as I found, psychosis is widely used, almost universally used in an involuntary commitment context. People are labeled with what the phrasing is, with psychotic features. So virtually every major diagnosis in the diagnostic manual has a dimension that allows the person to be labeled as having this thing, whether it be bipolar, depression, substance use disorders, dissociative identity, neurocognitive disorders. All of these can occur with psychotic features. And that means somewhere in there's a delusion or a false belief of some kind that the psychiatrist believes is causing the condition. So a person it even explicitly explains that if a person has an anxiety disorder, but it seems like it's motivated by a false belief of some kind, then the psychiatrist may even want to switch from an anxiety disorder to some other kind of disorder that has psychosis more explicitly written into it already. So this is the kind of flexibility that exists within the definition of psychosis and how it can be applied to virtually any kind of mental disorder and then used as an explanation for why a person is disconnected from reality. They're deluded, they're hallucinating, they're out of touch, they need to be involuntarily committed. And so because this is the case, what we often see in actual medical context, actual legal context when people are being committed, is that there's a very generic language that's just used to do this. So the details of a person's condition may be there in the medical records, but in terms of the actual commitment itself, most of it will hinge on a use of a term like psychosis, like lack of insight, like disagreeing with the psychiatrist about the diagnosis. And there are no established tests for this insight. And what is not uncommon at all is for commitment forms to actually be pre-signed. They may be stamped, or they use generic language, just saying patient lacks insight, unable to recognize the need for treatment. Something like that will be enough to move into the hearing, and that's often what's said. And so we've actually seen this kind of come out in public when certain institutions or individual doctors have been caught actually pre-signing commitment forms in this kind of way so that the actual treating staff can fill in details about the person, but the actual commitment criteria are already written up and stamped in place and signed by the psychiatrist if they want to decide they want to commit them. And this is, of course, totally not legal and creates a bit of a ruckus when it's discovered. But I discovered that it actually is fairly common as takes the case. Is the case. And so you actually have to go to the trouble of bringing this to the attention of news media and legislators and license bodies to try to get it to stop. As a result of these flexible notions of what psychosis is and how it can be applied to different people in different situations, essentially what's happening now is that psychosis and delusional false beliefs and hallucinations, all of these things can be seen virtually anywhere and are being seen everywhere. And this is what I really explore at length in the book, is how widely involuntary commitment powers are really being used across society right now, far more widely than generally seems to be recognized in the public. So I'm going to look at now some of the common uses of commitment powers for social and institutional management, is what I call it. Now we'll start with the obvious one that gets the most media attention and most people have heard about. And it's this deinstitutionalization group. The people who were supposedly put into the streets after the closure of asylums. So we actually did have some studies that tracked actually deinstitutionalized patients. And they found that in 23 studies done in 12 Western nations, several in the United States and Canada, in the majority of studies, there was not a single case of homelessness or imprisonment reported. So essentially over many, many years, they tracked actually deinstitutionalized patients to find out what happened to them and found that most of them had been successfully transitioned into group homes and supportive housing and so on. Even when there were some cases, it was less than 2% they found across these studies had ever been homeless or imprisoned as a result. So we sort of have this exaggerated narrative going on out there. And with this exaggerated narrative about what's happening with homeless populations, here's a great example of the kind of data we hear about. So California did a big survey just in 2023 where they found that 82% of homeless people reported a period in their life where they experienced a serious mental health condition. Look at these numbers. They're staggering. It's unbelievable. A quarter of homeless people are experiencing hallucinations. They're psychotic. Many more, up to 70%, experiencing depression, anxiety, and so on. So clearly, this is the dominant narrative out there, and it seems like, wow, something's really going on. Well, there's a whole bunch of things wrong with these numbers. Essentially, they're not controlling for impacts of homelessness itself. Who can be homeless without experiencing anxiety or depression? I don't know. I'm surprised those numbers are so low. I'd expect it to be 100%. They often include drinking and drug use as mental disorders. That's arguable. Now, they severely exacerbate diagnostic inflation. So these numbers are actually derived from people just self-reporting or a simple little screening survey that might ask 4 or 5 questions about how sad you were at a particular time. So these are known to dramatically inflate the numbers of people. And then they use lifetime prevalence rates. So look at that phrasing, reported a period in their life when they experienced a mental health condition. So these are people who essentially said, yeah, at a certain period of my life, I was really, really depressed or something like that. So what are those kinds of numbers in the general population? That's key because it's never done. They don't give you these numbers and then compare to the general population. Well, what do we know? In the general population, the lifetime prevalence of mental disorders is now 61 to 80%. 61 is the low end. I've seen studies now putting it above 80% of the population. That means 80% of us will at some point in our lives meet the criteria for a mental disorder. And the lifetime prevalence of hallucinations, surveys that have been done on people have found rates anywhere from 15 to 80% in the general population. So again, we're not actually seeing anything more than we would statistically expect to see in unhoused populations. And that's important. So what I'm essentially saying is, it's not that there's no mentally ill people or no people labeled with mental illnesses or nobody really, really struggling with serious problems in the street, but we've exaggerated the scope and significance of that particular aspect of homelessness. Now, why would we do that? Well, what I show in the book is, and what I can say here, is that we're doing it because it's just another tool for policing homeless people. It's a way of blaming them for their own conditions and aggressively trying to control them. Here's a couple examples of that. So a 2019 Disability Rights Oregon report that found that more homeless people in Portland had been arrested or detained under either criminal or psychiatric mental health laws than the federal homelessness count even found in the state. So in the city, I should say. So extremely aggressive policing of homeless people going on. Between 2015 and 2020, the Department of Justice Civil Rights Division settled with multiple states for unnecessary institutionalization of tens of thousands of people overall. And the justification for hospitalizing people is usually there's no other place for them. So they were unhoused people, and even though they no longer met the criteria for being detained, they were forcibly detained in these psychiatric institutions because psychiatrists just felt, well, if we let them go, they're just going to be on their own and they're going to decompensate and end up back in hospital anyway. So let's just keep them locked up. So the DOJ sues these states to get them to build affordable housing, to get them to build supportive housing. So this, again, example of aggressive policing of homeless people. And throughout all this, we'll also see high rates of racism and other types of prejudices playing out. So just fitting more broadly with that kind of policing narrative of unhoused people. And that's the real reason this is going on. Now, also, so now we get into the other types of people who are being subjected to involuntary commitment at increasingly high rates. And these are help seekers. So people who clearly aren't actually lacking insight into their own mental condition because they're actually seeking help. But what we see is high rates of voluntary patients being made involuntarily so that they can be treated against their will if they refuse a particular treatment. And this is so common that some states have actually written it into law. So, for example, Texas has written quite explicitly that a voluntary patient can be made involuntary if they disagree with the recommended treatment of the psychiatrist. They've just streamlined the process. Another example of this would be the 988, another crisis hotline. So, for example, these are people, again, reaching out for help, wanting to talk about their problems. And in 2022 alone, 988 sent police and emergency mental health services out to take people to psychiatric hospitals, 400,000 people in that 1 year alone. So this is a huge number of people who would usually then be subjected to a forced psychiatric evaluation of some kind and potentially a psychiatric detention longer term. And still more people are taken to psychiatric hospitals by mobile crisis teams. Other groups, we definitely see this really commonly in families, and the Britney Spears case was a prominent one that hit the news media. But this is actually very common in a day-to-day level, that one family member is trying to control or profit from another family member in some way. They're having an argument, they're a fight, they've got a long history of abuse. You don't really know the details of these families, but one family member helps get the other one detained in some way. Schools have started to use mental health laws increasingly. And in fact, wherever we can get more detailed data, we find that commitment rates of children are the fastest rising group within society right now. And it looks like this is primarily motivated within the school system, because where they have good data, like in Florida, we can see the rates actually drop during the summer months when school is out. And so what they're doing is, it's disruptive or distressed children in different ways. Disobedient children are being labeled as in need, as psychotic, and getting taken to psychiatric hospitals against their will. Nursing homes and long-term care facilities really like to use antipsychotics for behavior control, to tranquilize and induce docility. And when somebody puts up resistance to that, whether it's the patient themselves or a family member, then these mental health laws may be invoked to help force the drugs. I was surprised to discover how extensively workplaces have gotten involved in this. You can see some of the news coverage here about mental health laws being invoked to kind of grapple with accusations of racism or sexism in the workplace. And the employees are told, well, no, you've got a mental health problem. That's what's really going on here. And even licensed professions have it, where doctors may be seeking help with some sort of mental health problem, and they can end up in a coercive program of some kind. Mental health laws are invoked against them. I discovered that banks, airports, tax authorities, government agencies of different kinds fairly regularly use this to deal with complainants and protesters. There's even written policies. The IRS, for example, did several audits of their own program, where they were getting certain kinds of taxpayers. They were calling 911 on these taxpayers. Of course, some perhaps really were truly dangerous people uttering threats. That was a subcategory of this, but other ones would be people who were expressing suicidal feelings or just anger towards the IRS, or in some way the IRS agent felt that the distress they're experiencing was somehow risky to these people, and they were instructed to kind of follow this program of calling 911 and getting these people compelled into some sort of psychiatric evaluation. Another broad phenomenon here, we really don't know the full scope of it, but this is a great example, is fraud. So because it's, again, so easy to label anybody with psychosis or lack of insight, as I was discussing earlier, this has been learned by corporations, and they're using it for large-scale fraud. And this is a settlement with the biggest psychiatric chain in America, 200 psychiatric hospitals, Universal Health Services, settled with the Department of Justice for detaining people who, quote, did not require hospitalization, and they, quote, improperly used physical and chemical restraints and seclusion to keep these people detained, and bilked their insurance plans, or they bilked Medicare and Medicaid for these patients. And they settled for $117 million with the Department of Justice. And this is just one example of cases like this with other companies. And also, I believe, my understanding is that Universal Health Services is still under investigation for other facilities. This was just in some of the states. Mental health laws are frequently used against whistleblowers. I discovered some isolated cases of this and just wondered how common it was. And then I called up the Government Accountability Project, which is the primary legal organization that represents whistleblowers in America today, some very high profile people. And yeah, their legal director said to me that forced psychiatric evaluations and detentions of whistleblowers are a bread and butter harassment tactic. that basically when he has a new person conducting who's going to be a whistleblower that their agency is going to represent, it's something he often says on the very first day is, you're going to be forced into a psychiatric evaluation. They're going to try to label you as crazy. You could end up locked up in a psychiatric hospital for a period of time. Are you ready for that? Like, it's part of his kind of, get to know what's going to happen to you for whistleblowers. This was a case here of a New York Police Department detective, Adrian Schoolcraft, who was locked up for 6 days after, but for his good fortune, he actually had a lot of evidence to support what he was saying, and so he was let go rather than being considered paranoid about what his fellow police officers were up to. I don't want to say that these kinds are common, but it just gives you an example of how flexible these criteria really are again. So we've seen that anti-mask and vaccination protesters, in some cases, were forced into psychiatric evaluations, as well as people suffering long COVID. They were labeled as faking or delusional or dangerous to others in some way. And again, I don't want to suggest that this is really common. I don't know that it is, just that some cases like this did emerge, highlighting the flexibility. Similarly, I found cases of people who were experiencing climate distress being labeled as having psychiatric illness and finding that a very distressing experience to go through. And you can find writing about this where psychiatrists are actually saying, yeah, we should do this. We should lock these people up because they may be displaying irrational levels, whatever that means, irrational levels of distress thinking about apocalypse. So with all of this going on, there is a logical and very, very important question is any of it helping people? Because if it is helping people, you might say, well, okay, maybe we can accept that these sort of loose terms are being used and all sorts of people are getting detained against their will, potentially forcibly treated, if in fact we could show demonstrably that the vast majority of people derive benefits from this experience. Well, they don't. They don't. In fact, it's rarely even studied. We have very little data, as I discussed earlier. We aren't even tracking the raw numbers of people that this is happening to well, let alone doing any kind of outcome tracking to see if they're getting better or instead, as many people testify, getting worse, experiencing real significant harms from these experiences. I delved into the scientific evidence, and here are some quotes from the peer-reviewed literature that I came across to indicate where we're at internationally with our understanding of psychiatric detentions and involuntary treatment. So use of seclusion, physical and chemical restraints are, quote, very common in psychiatric hospitalization, despite a remarkable lack of evidence to support their use. Locked wards, constant monitoring, emergency medications, and so on, quote, are not supported by evidence and, quote, are difficult to justify. Here's another quote from a study that looked into, attempted to do a meta-analysis, attempted to do a systematic review of the evidence that was out there around the world on involuntary treatment. And they concluded, quote, psychiatric forced medication is a remarkably understudied practice. We have no evidence of reductions in serious violence or suicides from forced treatment. And we do have suggestions that, in fact, conditions may worsen, particularly suicides. There's many studies showing that suicide rates increase dramatically after hospitalization. And another quote, this is from a pro-force psychiatrist. I want to emphasize a lot of these things I'm quoting are actually from psychiatrists themselves who are pro-force treatment, supportive of forced treatment, and were extremely dismayed when they went looking for actual scientific evidence to back up the practice. And this is one, Torsten Jacobson, who wrote, involuntary treatment is, quote, based on tradition rather than evidence. So in summary, one study with a couple researchers that were linked to the World Health Organization, they also looked into this in 2019 and concluded, once again, as every other researcher had found, coercive interventions in mental health care continue to be used extensively, although there is little evidence they confer any clinical benefits, and they're often associated with negative outcomes. And as a result of this body of scientific evidence, showing that there was no support for forced treatment's effectiveness. And on the contrary, there was abundant evidence, personal testimony from people in bulk and studies, aggregate studies of these people talking about the harms that they experienced as a result of it. As a result of that, the United Nations, when it was developing the Convention on the Rights of Persons with Disabilities, concluded that ultimately it should be banned. And as a result, a number of related subcommittees from the United Nations have declared that forced psychiatric treatment is, quote, arbitrary detention under the CRPD and, quote, torture under the CRPD, and have affirmed the need to ban the practice internationally. Of course, that has not actually happened in the United States or Canada or in most countries, even ones that have in fact affirmed the CRPD have usually reserved the right to continually to forcibly treat people under mental health laws. So to summarize all of this then, flexible labels of psychosis and lack of insight are supporting involuntary commitment being used to detain and forcibly treat with numbing or tranquilizing medications an incredibly diverse array of people from many different walks of life and backgrounds. And often it seems to be motivated in some way, to some degree, by social institutional management purposes. So we need to be discussing this far more as a society. It's right now cloaked under the guise of it always having a helping intention, completely compassionate intention. But what I found in all of my research and what everyone else's research that I've found that's been serious who's looked into this, what we're finding is that, okay, mental health laws are actually being used much more aggressively for social institutional control of different kinds, for public safety reasons of different kinds, even without a good rationale for these being successful strategies for what they're trying to accomplish. So we need to talk about that a lot more, investigate it a lot more. We need better data. We need better outcome tracking to support that. Thank you.